عليكم السلام دكتور.
صوتي واضح عيني؟
واضح.
أوكي.
والسكرين هم واضح دكتور.
سكرين هم واضح؟ ماشي.
واضح.
نبدأ إن شاء الله. بسم الله الرحمن الرحيم. Our lecture today is in Neuro COVID. As you know, coronavirus 2019, COVID-19, a consequence of severe acute respiratory syndrome. Coronavirus 2, SARS-CoV-2. This is the name of the virus. SARS-CoV-2 infection. Emerging, as you know, in Wuhan, China in December 2019, and spread globally with massive impact on the health system, community relation, and economic. يعني خرب الدنيا كلها. Okay. Few words about the virus. The SARS-CoV-2 is most closely related to the beta coronavirus genus, which mainly infect the human respiratory system. They contain single-stranded, which is positive sense RNA genome, surrounded by a membrane envelope. The use of their spike proteins to infect this. This is the spike, which used to infect the host cell. The spike protein predominantly use human protein receptor. Which receptor? Is the receptor angiotensin converting enzyme 2 in the cell surface to invade the human cell. Since the outbreak of SARS-CoV-2 pandemic, it became increasingly even that, okay, it is primarily an pulmonary problem, but increasingly there is an extra pulmonary manifestation. This extra pulmonary manifestation can be directly or indirectly affected by the infection, which is called the extrapulmonary involvement. Many organs involved in extrapulmonary manifestation, maybe the eye, heart, kidney, intestine, endocrine organs, skin, vessels, and the nervous system, which is called Neuro COVID. This is the scope of our lecture today. This extrapulmonary manifestations of the central and peripheral nervous system need to be recognized, as they can strongly determine the outcome. Maybe until now we put it as a marker for severe cases of COVID-19. So it should be determined, should be you should have a guideline to deal with this extrapulmonary manifestation, the neurological, the Neuro COVID specifically. The source or the route for infection to the CNS, SARS-CoV-2 is a neurotropic virus with neuroinvasive capability. There is many viruses have this capabilities that directly invade the central nervous system through this is the mechanism, a neuronal retrograde route, and result in neurological pathology. Retrogradely from the peripheral nervous system to the central nervous system, and can reach the brain to cause these pathologies. There is a specific immunity system in the central nervous system. It started with what we called it blood-brain barrier, which is multi-layers. and the effective response of the nervous system protected to high grade from the invasion of the pathogen agents. So the direct invasion until now, it is not, at least it's uncommon. If you cannot say this is rare, it's uncommon. While the nervous system invasion, not selective advances of the virus, but until now, we can demonstrate cases with this invasion and cause central nervous system or nervous system in general pathologies. The spectrum of central nervous system patient is much, although it is uncommon, but it is much broader than so far anticipated, because many autopsies showed invasion of the virus, but in general with no manifestation. Is it due to proper immunological response in the central nervous system? Until now, we have no clear idea about that. Now, what is the neurological manifestation? We should know the details of the neurological manifestation to know how to deal with this manifestation. Is it a features or it is a complication? The manifestation include systemic feature of SARS-CoV-2 infection and the neurological complication of this virus. And this is completely different. If you remember, I think in the second lecture of neurological manifestation, I said there is many neurological features is reflection to systemic disorders. So sometime, and not sometime, the more common is neurological features in COVID, in SARS-CoV-2 infection, is a reflection of systemic rather than the neurological complication of the infection in this virus. This is the first time I give a lecture about Neuro Covid. I didn't give this lecture, although the pandemic started before 1.5 years, approximately 18 months, because until now, many disorders, we have no clear hypothesis about the mechanism. COVID-19 is a complex multi-system infectious disease that involves a set of currently unknown complications. The spectrum of the clinical manifestations, yani features and disorder, is continuously broadened. يعني شهر بعد month after month we have new data, and many disorders added to what we know previously. Therefore, further studies I need to evaluate whether this multi-organ failure are reflective of direct tissue viral invasion or a secondary systemic effect of the virus. And definitely, according to that, the management will change completely. Neurological features indicating central nervous system, peripheral nervous system, and skeletal muscle involvement, which is reported in considerable portion of severe cases. One can distinguish between minor neurological feature that's important for diagnostic recognition and case findings. Is very important because it consists with the diagnosis of COVID-19 infection diagnosis. But the major neurological disorder can affect the patient's risk of complication and death. And this is completely different. Minor and major. Minor is the features. Major is disorders. And disorders affected the prognosis, neurological disorders. The severity of neurological findings does not necessarily correlate with the criteria used to the classification of severity of COVID-19, which are based on feature of respiratory illness. Why? Because many neurological features can be found even in mild cases. So we should differentiate between minor and major, although it's, I should say, it's sometimes very difficult. Minor neurological feature of COVID-19, such as headache, anosmia, fatigue, dizziness, nausea, vomiting, muscle ache, appear to be rather common, even in mild cases of COVID-19. Another most common reported neurological feature is the smell and taste impairment. Major neurological complications of COVID-19 is something different now. Major neurological complication of COVID-19 include CNS disorder such as encephalopathy and encephalopathy, impairment of consciousness in patient with COVID-19 is very important clue for the severity. So we should deal, and I will take it in detail later, but encephalopathy is a marker for critical illness of the patient. Stroke and venous stroke is more than arterial stroke is one of the recognized complication of COVID-19. Myelopathy, as well as neuromuscular disturbance such as rhabdomyolysis and Guillain-Barré syndrome. Cranial nerve dysfunction, many cranial nerve, and there's a list of all cranial nerve with relatively different frequencies involved in COVID-19 infection. These complications generally are related both central and peripheral nervous system with no distinguished underlying mechanism. And this is what make the debate about involvement of nervous system in COVID-19. After 18 months, still there is many open-ended in the affair of Neuro COVID. SARS-CoV-2 COVID-19 neurological manifestation are reported to include symptoms related to central nervous system, peripheral nervous system, and the skeletal muscle damaged. And central nervous system, headache. Previously, in the previous slide, we classified it according to the major and minor. But now, I want to classify it according to the localization of the lesion. Is it central? Is it peripheral? Is it skeletal? Central nervous system is headache, dizziness, impairment of consciousness, and seizure. Peripheral nervous system, taste impairment, smell impairment, vision impairment, and nerve pain. Skeletal muscle damage, I will put it in a different entity. For this manifestation, with this distribution, the contribution of any manifestation in COVID-19 infection is not necessarily due to complication. Headache is very common and relatively as the يعني اخوان بالريسبيراتوري فيزيشن اسمع منهم اكثر يعني لان هم يعني in contact with patient more than the neurologist. Headache in cases of nervous system in our country is more than reported cases worldwide. But it's not necessarily headache due to neurological complication. Headache may be reflection of the central nervous system to the systemic infection and maybe due to neurological disorder, major neurological disorder. And here the physician need to differentiate between, because the difference is huge and the management is completely different. All type of seizure is reported in COVID-19. Focal, generalized, status epilepticus, myoclonic status epilepticus, non-convulsive status epilepticus. All these type reported, even the febrile illness in pediatric age group. Neurological complication may include either direct infection of the nervous system, of the nerve end, as we say, as we mentioned, the retrograde nerve retrograde route, or through secondary or systemic effect of immune system malfunction. And this is the most common mechanism of involvement of the nervous system by COVID-19. Immune system malfunction and vascular system dysregulation due to immune system malfunction. Neurological complication may include stroke, all type of stroke, meningoencephalitis, cerebral ataxia, and other neurological manifestation, and we will take it in detail. A novel CNS complication of COVID-19 nowadays, the authors raised the concern of myoclonus. But myoclonus remains speculative if myoclonus is infectious or immune mediated or post-hypoxic or due concomitant renal insufficiency. Myoclonus is one of the manifestations of metabolic disturbance and one of the manifestations of hypoxia in general, not only in COVID-19, in general. But is this patient with myoclonus have direct infection of the brain, or it is reflection of systemic? This is very important, differentiated. Myoclonus is an involuntary movement common among critically ill patients. It is characterized by sudden, brief, and sometimes repetitive muscle contraction, variably involving face, extremities, and the trunk, and can be seen and associated with a specific neurological disorder, or can result secondary for a host or toxic or metabolic trigger, including both mild and severe hypoxic brain injury and sedating medication. Myoclonus in general is divided into epileptic and non-epileptic. So it's primarily should be differentiated because it can be considered as a movement disorder or epileptic seizure. So from the start, it's difficult to differentiate. And added to that, is it in COVID, is it to direct involvement, or it is reflection for systemic illness, I mean hypoxia and metabolic disturbance. So, but in general, I should say, it is a marker for poor prognosis. A spectrum of encephalopathic feature. Those patients falls under the umbrella of altered mental status and may include confusion, delirium required sedation. In the critical care environment, where clinical neurological assessment is challenging, these features have potential to mask underlying inflammatory CNS syndrome, but it could be manifestation of hypoxia. So, as any cause of diffuse central nervous system lesion, it could be metabolic, it could be hypoxic, it could be septic, and added to that, in COVID-19, sometimes there is involvement in immune dysregulation, immune system response. And there is a big difference between the treatment of hypoxic encephalopathy, metabolic encephalopathy, like uremic encephalopathy, and involvement in cytokine storm, involvement of the nervous system in cytokine storm. Psychosis, which is reported in many patients. Psychosis, in this lecture, I put the generally the information will have a general agreement, but I asked my colleague about psychosis in our patient. Nobody said there is psychosis other than the association, the coincidental with cytokine storm. So, psychosis is a mental disorder in which patients have impaired sense of reality. Symptoms of psychosis can include hallucination, talking incoherently, agitation with persistent paranoid delusion, and florid hallucination. The etiology of COVID-related psychosis remain unclear, although most authors propose persistent immune activation and surges of inflammation. And I think this is the mechanism. And psychosis need immunomodulation and immunosuppression. As I said, my colleague said, there is no case of psychosis in patient didn't develop cytokine storm. So it's completely related to immune inactivation. The major manifestations can be classified according to the pathogenesis. Although, I should say, many disorders have more than one items of this classification. First, it is a direct viral attack toward the neuron, glial cell, or component of cerebral vessels or blood-brain barrier. Or it is secondary to immune reaction against the virus. This is the most common one. Or it is secondary to involvement of other organ, primarily the lung or the heart and kidney. Maybe due to side effect of a treatment applied during the acute infection, and we lose many patients due to side effect of immunosuppressant, for example. The last one, the pre-existing neurological disease. may become clinically evident or worsened with COVID-19. The patient have pre-existing problem aggravated by the SARS-CoV-2 infection. صوتي واضح؟ تسمعون زين؟
اي دكتور واضح.
Okay. At the beginning, neurological disease due to direct viral attack. As I mentioned, coronavirus are neurotropic and can enter the brain through various mechanisms. I think olfactory neural pathway, like other viruses, it is the route for entering to the central nervous system and cause inflammatory response, which can cause both peripheral and central nervous system manifestation. Direct affection of the CNS by virus is rare and may cause meningitis, encephalitis, and meningitis, encephalitis presented with usual headache, seizure, ataxia, pyramidal signs, and impairment of consciousness. Direct affection of the peripheral nervous system can cause hyposmia and hypogeusia, taste and smell impairment. The aberrant function of peripheral nervous system is evident because of observed taste, smell, vision, and neuropathic pain. Skeletal muscle damage in association with increased creatinine kinase level and the neurological manifestation are common among patients with severe COVID-19 infection. And here we should differentiate between skeletal muscle damage and myalgia, which can be a manifestation even in mild cases. واعتقد يعني كلكم عندكم من اهلكم انصابوا والمyalgia is very very common, but it doesn't mean there is a skeletal muscle damage, which is a complication, a major. Differentiation, creatinine kinase, everything increase, so there is muscle damage. Neurological diseases due to immune reaction, cytokine storm against the virus. This is the major devastating complication or neurological complication of COVID-19 infection, SARS-CoV-2 infection. Acute disseminated encephalomyelitis, what we called it ADEM. Acute hemorrhagic necrotizing encephalopathy, cerebral vasculitis, transverse myelitis, cranial palsy, Guillain-Barré syndrome, mononeuritis, cytokine release syndrome, associated cytokine release syndrome is the complication of virus, but cytokine release syndrome, associated encephalopathy, myositis, psychosis, obscureness, myoclonic ataxic syndrome, and stroke. ما أعرف ممكن بالسايد أنا نسيت أخليه stroke is very important complication. I will put it from the common toward the less common toward the rare. Although even the rare, and then in the pandemic, it doesn't mean the number of cases is low, because the number of patients is very high that make even the rare is a considerable number of patients. But the most common is cytokine release syndrome associated encephalopathy. Cytokine release syndrome, cytokine storm is the devastating complication of COVID-19 infection. Associated encephalopathy, it means involvement of the central nervous system, clinically manifested as disturbance of content of consciousness, then it may progress to this terms of level of consciousness, tremor, cerebellar, any behavioral disturbance, aphasia, pyramidal signs, cranial palsy, dysautonomia, any focal manifestation. And there is a reported cases of central hypothyroidism. The second complication is stroke, which include ischemic stroke, intracerebral hemorrhage, and the most common type is deep cerebral venous thrombosis, which is frequently reported in patients with COVID-19 infection. Why we consider stroke as a complication of immune dysregulation? Because cytokine storm can lead with what we called it COVID-induced coagulopathy. So it is part of hypercoagulable state. And hypercoagulable state give venous stroke more than arterial stroke. Can be presented as hemorrhagic and ischemic in the same time. The venous, I say, the ordinary venous هي يعني هسه ما اعرف توفى ولا لا يعني بس عندنا هسه بالار سي يو patient with hemorrhagic stroke. But the hemorrhagic stroke could be arterial, but the real mechanism we don't know until now. So the cytokine storm can lead with what we called it endothelial dysfunction. The endothelial dysfunction of the vessels participate in the induction of prothrombotic state. This prothrombotic state can lead physiological response called immunothrombosis that involve blood coagulation, platelet aggregation, the key effector of innate immune response that delimitate pathogen spreading through the vascular system. But no, يعني kind of defense mechanism, but it will lead to obstruction of the vessels. While the immunothrombosis is inherently beneficial via local control of infection، يعني يسويها الفيزلز يسد نفسه حتى ما يخلي يعني don't prevent the spread of the infection. Endothelial dysfunction accompany the hyperinflammation response due to SARS-CoV-2 infection might lead to state for COVID-induced coagulopathy. هذه اللي تصير in special area to prevent the spread. لا ممكن الاندوثيليال هي دائما هي مشكلتنا دائما in COVID هي endotheliopathy. Endotheliopathy can cause this state in hypercoagulable state which can obstruct major vessels, venous and arterial. There is another kind of stroke, small vessel stroke. If you remember from the lecture of stroke, it is result from is not atherosclerosis. It is due to lipohyalurosis. Lipohyalurosis can be triggered by COVID-19, although direct mechanism to viral endotheliitis, endothelial layer of the vessels cannot be ruled out until now. DIC, disseminated intravascular coagulation, is also a complication of COVID-19 and it's related with its related parameters like thrombocytopenia and D-dimer have frequently reported in COVID-19 patients. Guillain-Barré syndrome, the classical Guillain-Barré syndrome, which induced by inappropriate immune system response, reported and then confirmed in patients with COVID-19 disease. It is an immune-mediated polyneuropathy. Patient presented with rapidly progressive symmetrical limb and or cranial nerve weakness, loss of deep tender reflex sensory and dysautonomia as a manifestation. Actually يعني احنا حقيقة from the start يعني start of pandemic, we wait for the cases of Guillain-Barré. And this is the mechanism. And with this especially with this virus, with complication of immune dysregulation, so we should expect Guillain-Barré syndrome. Guillain-Barré is a syndrome rather than a disease and can cause by many triggering factor. So at the start of pandemic, we wait for the cases of Guillain-Barré, and after 2 to 3 months, cases with Guillain-Barré start to be evident in patients with COVID-19. The main pathophysiology for clinical presentation is demyelination and or, in advanced cases, damage to peripheral nerve. All the variant of Guillain-Barré-like syndrome is reported in patient with COVID-19. Acute disseminated encephalomyelitis, ADEM. ADEM is an autoimmune demyelinating disorder. The condition typically triggered by viral infection in general and lead to rapid onset multifocal neurological deficit. Among patients with COVID-19, ADEM should be considered a potentially treatable cause of profound encephalopathy. So, for diagnosis of acute disseminated encephalomyelitis, we should have multifocal lesion with encephalopathy. Other causes of encephalopathy with multifocal neurological deficit is cerebral vasculitis. So we have now, at least until now, we have cytokine release syndrome associated encephalopathy can give multifocal with encephalopathy. ADEM can be presented with multifocal lesion with encephalopathy and cerebral vasculitis. Maybe, and we will have a rare fourth cause. Maybe it is difficult to differentiate between these causes, but at least until now, the treatment is the same. Acute hemorrhagic necrotizing encephalitis. This is a rare condition, but should be considered. hemorrhagic necrotizing encephalitis, and other than COVID-19, it is considered as direct viral infection. But in patient with COVID-19 infection, acute hemorrhagic necrotizing encephalitis reported only in those patients with cytokine storm. So what is the mechanism behind this? Is it direct or is it indirect? It is a distinct clinico-pathological syndrome with patients suffering from rapidly worsening encephalopathy and later on may develop coma with the first 2 weeks of severe illness and hemorrhagic necrotizing parenchymal change in neuroimaging. So it is a clinico-pathological. The pathophysiology of this syndrome is unclear but hypothesized to occur due to cytokine storm, blood-brain barrier dysfunction, and direct viral mediated endotheliopathy. So I think it is a direct, but in an environment of the cytokine storm. So the cytokine storm kind of triggered endotheliopathy, which lead to this type of encephalitis. It is direct, but it's not direct due to nerve retrograde rot. This is hematogenous rot. So this rot is triggered by the cytokine storm, immune response dysregulation. This is my opinion. I don't know, maybe I'm wrong. Diagnosis of this disorder require high index of suspicion in patients with high unexplained persistent severe encephalopathy associated with COVID-19 infection. Most patients have elevated inflammatory marker and severe lung disease with hypoxic respiratory failure requiring mechanical ventilation. MRI is imaging modality of choice with the distinct neuroimaging pattern. It needs immunomodulation therapy. Acute transverse myelitis, like an ordinary acute transverse myelitis. As you know from the lecture of the myelopathy, transverse myelitis can be due to viral or post-viral infection. In COVID-19, mostly due to it can be due to paraviral, but mostly this is due to post-viral immune dysregulation, immune response regulation. Okay, this is due to secondary to immune response of the COVID. Now, there is secondary disorder secondary to the affection of the lung, heart, and kidney. Many patients have hypoxic encephalopathy, uremic encephalopathy, and maybe hypoxic encephalopathy due to heart problem. Last week, a patient died from myocarditis in our hospital. Cardiac involvement may be responsible for cardioembolic phenomena, ischemic, which can lead to ischemic stroke in this mechanism, or ischemic stroke due to hypotension. Maybe this cardiogenic shock can lead to CNS vessels insufficiency. Neurological disorder may be due to side effect of a drug, antiviral and other drug, immunosuppressant, can lead to many neurological disorder like toxic myopathy, critical illness myopathy, critical illness neuropathy, and rhabdomyolysis. And maybe due to immune suppression, there is secondary infection, for example, fungal infection. Lastly, there is a pre-existing neurological disease. The pre-existing neurological disease may be deteriorated during acute viral infection. So, the mortality rate high with patients with chronic diseases. Maybe it is not fatal diseases, but it aggravated during the viral infection. And thank you very much for your kind attention. إذا أحد منكم عنده سؤال أو كومنت أو أي شيء. أوكي، يعني إذا ما